Good. So I'm going to start now. So dry eye disease, the reason why we are talking about it is because it's becoming an increasingly prevalent problem in ophthalmology. It is one of the three most rapidly growing eye problems among the aged. And where we have reliable data, like from the US, it apparently accounts for 1 out of 4 visits to the ophthalmologist. We do not have such data pertaining to India, but the literature shows us that both the prevalence of dry eye disease and Meibomian gland dysfunction is more in the Asians, and therefore we can assume from this that we are also seeing a significant burden of this problem in our clinics. This used to be a problem of the elderly, but with the increasing use of computers and the software professionals in the last decade or two, we have added a significant proportion of the younger group into this. And in the last 2 years, with the pandemic happening and with a lot of the education now being from home and online, the increasing use of video display terminals among children has resulted in a lot of them having similar symptomatology as well. And so now the burden of this disease spans the entire gamut of people, right from children all the way to the elderly. And therefore, it's worth spending some time looking at this problem in detail. Although we speak about dry eye disease in the context of tear film and tear volume, we must remember that the ocular surface is a fairly, there are a number of events happening on the ocular surface, and maintaining the ocular surface homeostasis is actually a fairly complicated process. Most of us take it for granted because we have comfortable eyes. But when you have dry eye disease, there is always a significant amount of inflammation that is present on the ocular surface. And whenever there is inflammation in dry eye disease, very quickly the Meibomian glands get recruited into the mealy, and there is Meibomian gland dysfunction as well. So if you do not treat the dry eye disease right at the start, meaning you do not take care of the tear film instability, you do not take care of the inflammation, and you do not take care of the Meibomian gland dysfunction, very quickly it cycles up into what is called a self-perpetuating vicious cycle, brings in the other two, and over a period of time, the ocular surface becomes a hotbed of inflammation and other problems, and that is what most of us see in our clinic. So even though we're talking about it as dry eye disease, please remember that there are multiple things that are happening on the ocular surface that we must be aware of. One of the problems that we've always faced in testing for this particular condition is that there is no single gold standard dry eye and symptom. We also know that the signs and symptoms do not correlate very well. And most of us still rely on a clinical evaluation, this slit lamp examination, where we try and pick up the signs of dry eye disease to treat it. When we do perform tests to look at it, there are various problems because none of these tests have the absolutely required sensitivity and specificity. And even for the few that we do have and we perform them, if you look at the numbers, there is a big overlap between that for the normal and for the dry eye patient. For instance, a Schirmer value, although you have a cutoff, a Schirmer value of between 12 and 13 is neither here nor there. So you can't really say below that is dry eye, above that is normal. So we use cutoffs, but there is a range given in each given patient. And therefore, we believe that when you do more tests, we tend to get more data, and therefore we can segregate these patients better. We shall see if that is necessary. Now, the current evidence-based literature that we have for dry eye disease, which came out about 2+ years ago, is the DEWS-2 report. And they basically suggested that we ask a series of questions. And if these questions in the clinic seem to indicate that the patient has a dry eye problem, we do a formal estimation of the symptomatology using either the dry eye questionnaire 5 or the ocular surface disease index. And they've given you numbers, a greater than 6 score on the DEQ5 or a greater than 13 on the OSDI suggests a significant dry eye. And then they suggest actual tests. These objective tests include the non-invasive breakup time, although they do say that if you don't have access to it, you could use a fluorescein breakup time. Measuring the osmolarity, because these are the key markers of tear film instability, and ocular surface staining, which we look at on the cornea, the conjunctiva, and the lid margin. If any one of these tend to be abnormal, then we do conclude that there is a loss of homeostasis of the ocular surface. And then we go on to try and distinguish whether the patient belongs on the aqueous dry eye end of the spectrum or the evaporative dry eye on the spectrum, because we now believe that there's a spectrum and people exist within it. We no longer categorize them into two distinct compartments. In order to distinguish this, we have to do an anatomical evaluation of the Meibomian glands as suggested by them, which is infrared meibography. We have to look at the output of the Meibomian glands, which is the lipid layer of the tear film, and we have to measure the tear volume itself from the tear meniscus height. So these are the tests that have been suggested by the DEWS-2, which is the current gold standard, which therefore means that the evaluation of this particular problem is becoming increasingly complex. Because when you add fluorescein using a teardrop to dilute the strip and then put it in the eye, it's making it unphysiological, and we'd like to measure the breakup time on the surface without adding any tears to it. The NIBUT has come into force. So a grid that is reflected from the cornea, we look for breakup in the grid, and this machine will detect when this happens, where it happens, and this is the non-invasive breakup time. In order to give us a measurement of the tear volume, because the Schirmer has many limitations, it is suggested that you directly measure the tear meniscus. Again, requires a device and a highly magnified photograph of the tear meniscus. We also want to measure the lipid component of the tear film, and this requires a device that uses interferometry. To look at the anatomy of the Meibomian glands, we need an infrared Meibographer, and we can also document the redness score, which is suggestive of inflammation on the ocular surface. And all of this can be done by a single instrument, which measures, among other things, the blink completeness and so on. And it gives you a very nice composite report like this. And in order to basically measure the osmolarity, which the DEWS-2 suggested, you need a separate device, the tear lab device. And if you want to quantify the inflammation, the one way that we can do it now is to use the inflammatory device, which basically will measure the levels of MMP9, matrix metalloproteinase 9, on the tear film as a marker of inflammation. So the problem is, apart from this, the DEWS-2 recognized that also we're talking about the dry eye and the tear film, a number of ocular surface conditions can coexist, can be impacted by the dry eye, or can add on to the dry eye as aggravators and increase the burden of disease. And therefore, we must look for these as well. So our testing process must be designed to look for the impact of these various conditions on the ocular surface and the tear film as well. So if I were to quickly summarize this whole evaluation process, the testing that we do must help us detect the presence of a tear problem, must try and help us decide whether it's an aqueous deficiency spectrum end of the spectrum or an evaporative end of the spectrum, pick up the presence of inflammation, which, as I said, is coexistent in almost every dry eye, look for these other conditions which are shown on the slide and their impact on the ocular surface, and finally, the proof of the pudding is in the eating. We must know whether this dry eye disease is affecting the health of the ocular surface. So as we just saw a bunch of tests. I showed you an instrument which could do that, and then we added 2 more devices to it. All of this makes this whole process very complicated, very expensive, and we are having to use technology that is not very familiar to most of the ophthalmologists at this time. It's a time-consuming process, can take between 25 to 30 minutes, and we need a lot of equipment, and this becomes an equipment-based process. Since this is so important and we're seeing it every day, the question is there a simple technique that everyone can do which can help us achieve the same goals? And therefore, I'm going to try and look at ocular surface staining with fluorescein, which is very simple and which all of us do in our day-to-day clinics, to see whether we can use this as a measure of what it is that I was saying. So if you look at fluorescein in this context, it can definitely help you pick up the damage to the surface because the epithelium, which is unhealthy, will stain. We can use it to stain the tear meniscus, and while you can't actually measure it at the slit lamp, it can give you a good idea of whether this is reduced, normal, or elevated. One aspect that we didn't really speak about in tear disturbances is the tear clearance, or the ability the tear to turn over at a normal rate, and fluorescein can help you to look at the fluorescein clearance test, which helps you decide about the tear turnover. We can look at it in other conditions that affect the ocular surface, like in injuries and burns, infections which affect the surface, leaks from blebs, contact lens use and its deleterious impact on the ocular surface. We can look at the LASIK, where we actually cause neurotrophic changes, and in this case, there's an epithelial ingrowth. We can look at folds in the LASIK flap using fluorescein. Basically, this will again disturb the ocular surface, and if you have any elevated lesions leading you to suspect a tumorous process, fluorescein can again work with you. So in order to understand this process of fluorescein staining, we first have to understand some of the basics of this. So here we have the surface of the corneal epithelium, the flattened specialized squamous cells, and the corneal epithelium itself in cross-section is 5 to 6 layers thick, starting from the base up till the surface. And if you look at this cartoon, individual epithelial cells are joined by tight junctions. And here we have what are called the microvilli on the epithelial surface. These are projections which increase the surface area, over which you have the membrane-associated mucins, and together they form the glycocalyx. But once you go into the deeper layers of the epithelium beyond the superficial layer, we have gap junctions, which are more porous, and the importance of this we shall see. So when you see staining in the epithelium, what it indicates is there could be death of these tight specialized cells. There could be a loss of these loose junctions from toxicity, from medications, or from other disease processes, or the cell could have lost its glycocalyx, and in the absence of the glycocalyx, the fluorescein is able to stain it. Free mucus can stain, and once the dye gets past these tight junctions, it can diffuse through the deeper layers very easily. And one of the things that we use the term is superficial punctate keratitis. So this is what we see on the cornea. And then basically when you look at the slide itself, what it indicates is either loss of individual cells, loss of tight junctions, or loss of glycocalyx. And that is why you get this fine spotty staining. Once the disease progresses a little more, apart from these, you can actually see some increased cell death as well. So what we're seeing is a loss of some of the layers of these cells. So instead of losing the entire cell layer, maybe 2 to 3 layers are gone. And therefore, you see a coarser or a larger area of staining. So this is called a punctate epithelial erosion. You can also get what is called a punctate epithelial keratitis, where instead of loss of cells, you see a heaping up of the cells. And this can be seen when you have an adenoviral or microsporidial lesion affecting the corneal surface. And the way to distinguish these slightly larger spots from the erosions is to do a slit. So here, because of the heaping up of the epithelium, this lesion will be convex, whereas in the erosion, there is loss of cells and it will be concave. And of course, when the disease progresses and the damage increases, you will see a loss of all the layers of the epithelium. This is the frank epithelial defect. And if you look at the surrounding epithelium as well, you can see the lack of health and the shattered right reflex, meaning that it's a very roughened epithelium. You can get transient spotty staining in a normal epithelium as well. And here it is because a senescent cell or an aged cell undergoes programmed cell death or apoptosis. Because it is programmed, even as it is dying and shedding, the underlying cell has taken up its role, the tight junctions are formed. So you may briefly see a small area of pooling in that area, but this will very quickly go in and take care of it. As opposed to this, on the right, you see pathological staining, where it's a necroptic cell death, where it dies with a lot of inflammation. And since this is a sudden event, the underlying cells are not prepared, and the dye is able to very quickly diffuse through the gap junctions in the deeper layers, and you see this larger area of stain when there is disease. When you have fluorescein on the surface, when you have too little of it, obviously there is no fluorescence. And as you increase the amount of fluorescein, as you can see in the tear meniscus here, the fluorescence increases. But paradoxically, as you look at this slide, as you increase the concentration beyond a certain point, again the fluorescence decreases. So if it is less than 0.01%, there is no fluorescence. But if it is more than 0.25% as well, there is no fluorescence. That is because in a very densely packed fluorescein stained tear film, the fluorescein molecules tend to absorb and cause interference of the reflected light, and you don't see it well. So somewhere in between is the sweet spot, which is 0.1 to 0.2%, somewhere here at the peak of this curve. And therefore, what you need to do is to put 1 microliter of the 2% fluorescein on the strip, meaning a very small amount. And this will get diluted in the 10 microliters of tears on the surface to give you the ideal 0.2%. So to remember, 1 drop is about 30 to 50 microliters. If you put this much of a fluorescein stained drop onto the surface, you're overdoing it. The ideal amount is that small amount so that the cul-de-sac and the normal tear volume of 7 to 10 microliters will dilute it properly. So just look at this video here. So basically, this is my clinic assistant with a normal ocular surface. So in the first instance, I've taken a drop of diluent on my fluorescein strip, and I'm putting the entire drop into the cul-de-sac. So you can see here that there's a large amount of fluorescein that's going into the eye. The second is the ideal way to do this. I put the same drop of diluent on my fluorescein strip, but then I shake the strip vigorously and then touch and put a little amount of fluorescein. This is the exact amount that I want. So in this example, you can see that the tear film is stained with fluorescein, and therefore any finding there will be masked. Whereas when you put the smaller amount, you can see the fluorescence there, but you can see the surface of the cornea as well. So if there's any subtle finding in the cornea, we will be able to pick it up better. When we use light to excite the fluorescein on the ocular surface here, it will be nice if we can use the exact wavelength that will excite the fluorescein, and therefore we use a cobalt blue filter, because this is the absorption spectrum, and that is what the cobalt blue filter allows to go in. After the excitation and the fluorescence, both the blue light and the fluorescent light are being emitted. And if you want to see the fluorescence better, you need to interpose a rattan filter, which blocks off, which allows the light only above 510 nanometers, which is the emission spectrum. So the blue light is blocked off and you can see the spectrum of emission better. This is a healing corneal epithelial ulcer. You can see a small area of staining in the center where the defect is still present with the cobalt blue fluorescein. But this is what happens when you interpose the yellow filter. Similarly, post-DALK, somebody who has dendritic viral keratitis, which is healing, you can see the dendrite breaking up with the fluorescein and blue light, but you can see it a lot better with the green light. And this is a last example of an elevated lesion staining with the blue light and with the yellow light. And this is an ocular surface tumor, which is picking up better. So the use of the yellow filter enhances the ability to pick up defects or changes on the cornea with fluorescein. But where it is really useful is when you're looking at the conjunctiva. When you use fluorescein on the conjunctiva and the blue light, we normally can pick up nothing because the blue light is intensely reflected by the sclera. So we use a dye like lissamine green. So when you use a dye like lissamine green, basically you can see the area of staining. You can get the same area of staining when you use your fluorescein as well. But in order to pick it up, you need the yellow filter. So if you have an yellow filter on your slit lamp, the only dye you need to look at the entire ocular surface in our condition of interest is fluorescein. You don't need a rose bengal or a lissamine green. Many of our slit lamps don't have these yellow filters, but these are fairly cheap devices, about 3,500 rupees. You can buy them from the net. And basically, this is held in front of the objective when you're doing your staining process. So when the light comes in towards your eye, you can use this to block off the blue light and see the enhanced fluorescence. So this is an example of what I was saying. You put too much fluid in the film, the fluorescein blocks this pattern. You have to wait for a few seconds for it to dissipate before you can assess the staining. Now, this is a dry eye. I put the 0.1 microliter here. There is not enough of tears to dilute it. So again, you have to wait for some tears to come in and dilute the fluorescein for you to see the entire picture. So too much fluorescein is not good. If you don't have enough tears, again, you have to give it some time. So the timing is also important. So this is before we put it in. This is by about 2 minutes. You see the exact fluorescein staining. This is the maximum amount you can leave. This is at about 4 minutes. And basically, this is at about sorry about that. This is at about 12 minutes. You can see that the dye is extensively diffusing. So you don't want to wait too long once you put in the fluorescein, and you need to assess it or read the condition by about 2 minutes. This is a patient I've been treating for a Murans ulcer who came in with a recurrence of symptoms. I put in the dye, I see this. So I'm worried that his entire Murans is again recurring. But then if you stop and wash away this dye with some tear substitutes, you can see that the only area of staining is here. So here you have a crater from the earlier Murans where the dye is pooling. So with fluorescein, you need to distinguish between pooling and staining. Once you put it in the correct way and you've learned to assess it properly, then we have to have some kind of a grading that happens on this. So basically, we can use this kind of a division of the ocular surface into 3 parts. This is what Van Bichterveld suggested. You look at the staining score here, here, and here. Each of this goes from 0 to 3 so that you can have some idea of the amount of staining. 0 is no staining, 3 is extensive staining, and 1 and 2 are semi-quantitative in between for a score of 9. I also like to divide the cornea into 3 parts, the upper, middle, and lower 1/3, so that this I can also see not just the amount of staining, but the area of staining that is happening on the cornea. You can also use the dye to look at the upper lid. This is the lid viper area, which is the terminal 2 millimeters of the upper palpebral mucosa, which has the most contact with the ocular surface when you blink. And you can look for the line of marks on the lower lid. I've shown it here with rose bengal, but you can pick it up with fluorescein as well. This line outlines the openings of the Meibomian gland orifices. So in conditions where you have Meibomian gland dysfunction and the oil secretion is not there, basically this will tend to move further outwards towards the anterior border of the lid. The reason why we want to divide the cornea into 3 parts and look at the staining in each part is because if your staining is primarily in the lower 1/3 of the cornea, it indicates lid margin disease. If you have staining in the upper 1/3 of the cornea, this indicates some allergic changes, possibly due to upper lid disease. And if you have changes in the middle third or the exposed interpalpebral cornea, this is usually suggestive of dry eye disease. In a moderate dry eye disease, the uppermost 1 to 2 millimeters of the cornea will generally be protected because the upper lid tends to protect that area from desiccation. But if you see staining across the entire cornea, including the upper 1 to 2 millimeters, then you can think in terms of toxicity, possibly from preservatives of the drops that you're using, because the preservative and the drop will get into the tear film, go under the eyelid, and stain the entire area as well. In the conjunctiva, we can look at the upper one, the bulbar conjunctiva, because in superior limbic keratoconjunctivitis, this will stain from the frictional trauma from the upper eyelid. And if you have a conjunctivochalasis, which can interfere with the proper flow of the tear film and result in significant symptomatology, the traumatized conjunctiva will stain. I'm showing here lissamine green and rose Bengal, but if you have an yellow filter, you can pick up these exact same changes with fluorescein itself. Medially, if you have something like OCP or canaliculitis, inflammation to the conjunctiva can be picked up. And temporarily, this area in angular conjunctivitis will be inflamed and will take up the stain. Like I said, in the lids, you can look at the upper lid. You can look at this lid viper area. You can look at the extent of staining as far as the width and the length is concerned to decide about the significance of the lid viper epitheliopathy in this particular patient. And as I said, this is the line of marks. And if you don't have the oil coming out of the Meibomian gland orifices because of dysfunction, the tears can spill over further, and this line will migrate more anteriorly on the lid margin, telling you about the lid condition of the Meibomian glands. So as far as the other correlations are concerned, when you put your drops in the eye, most of us put it in the lower fornix. And if you see this kind of an inflammatory state with staining of this little area of ulcerated conjunctiva, and if this ulceration and angry looking conjunctiva is limited to a line below a line joining the medial and lateral canthus, we tend to think in terms of a medicamentose. As you can see here, the superior bulbar conj is quite uninflamed. It's mostly here. So this was a toxicity from a medication. And in the early stages, if you see the corneal staining and compare it with the conjunctival staining, you will see far more corneal staining when you have a toxicity than conjunctival staining, because the cornea is generally the more delicate epithelium. The other correlation we can make is when the eye is significantly inflamed, when you have patient with extensive symptomatology, when he has significant redness of the ocular bulbar surface, but if you have conjunctival and corneal staining, which is very minimal, then this is a clue that inflammation is the primary pathology happening on that ocular surface. So we talked a bit about ocular surface staining. The question then is, how important is ocular surface staining? This is not necessary for every eye exam that we do. So somebody who comes in for a routine eye exam, probably we can do away with just a clinical evaluation and we don't need this. But when we have patient symptomatology that suggests a dry eye or other ocular surface disease, then as I just showed you, the staining can help you in multiple ways, detect the presence of the dryness and other issues, as well as some of the other conditions that may be happening on the ocular surface and complicating matters. We also do this because if you have a patient who has a known underlying systemic disease like rheumatoid arthritis, which is known to be associated with dryness, and he tells you, doc, I'm a rheumatoid arthritis patient for the last 7 years, but I don't have any ocular problems, you still have to stain to look at the ocular surface, because in this kind of a disease, there is significant neurotrophic damage on the surface and the eye will look white, the patient will be asymptomatic. But many times I've been surprised when I put the dye, I get a score on the surface of 6 or 7 out of 9, meaning that there is already extensive damage in this quiet looking eye. The staining helps you to not just detect the presence of a disease, but as I showed you, depending on where it stains in the cornea, where it stains in the conj, where it stains in the lid, we can diagnose different disease processes. The amount of staining can help us grade the severity of the disease we are treating at that point in time. And when they come back after we basically treat them, we can prognosticate and monitor the progress of the disease and whether the treatment that we have subjected them to is doing the desired work and it's getting better. So if we look at the process of fluorescein staining that I've just spoken about over the last 20-25 minutes, what is the verdict? We'll go back to that initial slide that we started this talk with, saying that we wanted something that will help us to evaluate these patients who present to us, to detect the presence of dry eye, to look basically to decide whether it's aqueous deficiency predominantly or evaporative. We wanted to look for the presence of inflammation, try and diagnose the other conditions that may be operating on the surface, and finally detect the health of the surface. So basically, like I said, we can look at the volume of tears by the fluorescein stained tear meniscus. We can look at the breakup time, which tells you the degree of protection from the oil film on the tears, telling us how much of evaporative dry eye there is. We can use it to look for inflammation by looking at the fluorescein staining of the conjunctiva, because one of the important markers for inflammation is the amount of fluorescein staining. This has been shown in studies. We can look for the presence of other aggravating conditions, for instance, in this case, lid viper, superior limbic, conjunctivochalasis, and so on, as I just showed you. And the amount of staining of the all-important corneal epithelium will tell us the deleterious impact of both the dryness and these other conditions on the health of the ocular surface, which is ultimately what we are interested in. Because if you can keep the ocular surface healthy and keep the epithelium going well, then much of the damage that occurs and much of the morbidity can be prevented. So as far as fluorescein is concerned, this is basically a very simple test. It is inexpensive. Each strip costs about ₹1 last I checked. It is a familiar technique. All of us are familiar with it right from our first day of ophthalmic training. We've been using it. It's a very quick process. It takes less than 3 to 4 minutes to do everything with fluorescein. And essentially, no equipment is needed. Maybe if at all, you need to buy that 3,000, 4,000 rupee yellow filter to enhance your ability to look at the conjunctiva with fluorescein. But if your slit lamp luckily already has that filter, then you don't need to buy anything more at all. So in this first talk, in this particular session, before we go on to the other aspects of dry eye, we just wanted to focus on some simple objective way by which we can try and get most of the information, because I know in the Indian context, most of the general ophthalmology clinics which see a large burden of this disease do not have access to the sophisticated and fancy equipment that I showed you in the beginning. And so even without all of that, I think we can do a fairly good job in picking up the presence of this condition in our patients.